Hello, and welcome to this episode of In Discussion With from Pharmacy Update Online. Today I'm talking to Hilary McKee about tackling polypharmacy in rheumatology clinics. Could you start by introducing yourself?
Yes, my name is Hilary McKee. I'm a consultant pharmacist. I work in Antrim Hospital in Northern Ireland, and I've been doing this job for about 25, 26 years in Antrim Hospital.
And can you give us a brief overview of your current role, what your job involves?
Yes, I'm very much patient-facing in my role. So I run my own rheumatology clinics, which are basically review clinics for patients, mainly with inflammatory arthritis, but with all conditions right across the rheumatology spectrum. And what happens is that the consultants will make the diagnosis, and then we will share the patients, and I will do a lot of the treatment management decisions.
You recently ran a workshop at the European Society for Clinical Pharmacy Annual Symposium. You explained how you work as an independent prescriber in your clinics, and you discussed some of the patients that present in the clinic. But first, could you take a few minutes to tell us how you got started in rheumatology clinics?
I started a very long time ago, longer than I care to imagine, and I applied for a job as a pharmacist in rheumatology, which said there would be some patient-facing element. Now, whenever I started, there wasn't any patient-facing element, but what I did was I was kind of the go-to for the one rheumatology consultant that we had at the time. I went to the ward rounds, I answered all her queries, I got whatever she wanted. And then about 6 months into that, we had a new drug come on the block, which at that time was leflunomide. And our GPs, because it was new, they weren't willing to prescribe it. So the consultant said to me, would you undertake prescription of this drug, handing it out, bringing patients up? And so really it was a supply function. And as that developed, patients were coming up and it was, how are you? How are you doing? Have you any side effects on this drug? And that is really where the clinic started. A short time after that, we started teaching patients to self-inject methotrexate before the commercial product was available. And that was a huge step because methotrexate being cytotoxic in inverted commas, although we say it's not cytotoxic at the doses we use, but there were a lot of hoops to jump through. And we started a self-injection clinic, which was part of my clinic. And then as things developed, it's just got better and better with the independent prescribing eventually coming into the clinic.
How does polypharmacy, that is, multiple drug therapies for one patient, become a problem in rheumatology? Surely there are clear guidelines for treatment in rheumatology.
Polypharmacy becomes a problem for patients in all aspects of their treatment. It is very easy to start a patient on a drug, and in rheumatology, we may start them on one drug and another one to help with the side effects. We then maybe, for example, methotrexate, we might start them on methotrexate and we'll give them folic acid alongside it. Maybe they're a little bit sick and we'll give them cyclizine or something to stop them being sick. They're probably on an anti-inflammatory, and with that, they're on a PPI. And there suddenly you have 5 medicines with somebody who previously didn't have any. And if we add things in, sometimes, for example, some of the drugs that we would use might increase blood pressure. So we'll add something in to control the blood pressure. And before you know, you have a whole concoction of medications. And that's right across all disease areas, not just rheumatology.
Mm-hmm. You mentioned prescribing cascades during the workshop. Could you just clarify what that means?
Yes, it's really the idea that you treat a potential side effect as a new symptom and you give a medication for that. And suddenly you take, as I said, you might take an antiemetic for the sickness caused by a drug, or you may need a blood pressure tablet because the drug has caused your blood pressure to go up. So that is a prescribing cascade. You start with one and suddenly you end up with maybe five, six, and even more drugs. Actually, the most drugs I ever saw a patient on were 42 medications, which was horrendous. And that was just because things had kept being added and nobody had looked to stop anything.
Mm-hmm. Does methotrexate treatment present special problems?
Yes and no. People are traditionally very afraid of methotrexate. Both patients and staff are a bit hesitant about using it. We would maintain that the doses that we use in rheumatology are not particularly immunosuppressant. Yes, they are immunosuppressant, but not the way the chemo doses are. So we are not afraid of it to the same extent that other disciplines may be. It's actually a very good drug and it's a very safe drug. And as you know, there's a lot of drug monitoring with it. So the aim, as we tell our patients, is to try to spot a problem before it becomes a problem. And then it's very safe.
That's useful to know. Now, what is the role of cannabis derivatives in rheumatology?
That is a big question. More and more patients are coming into us. They're buying cannabis derivatives on the internet. We don't tell them not to take it. There haven't been enough studies to say what the benefit will be. But I mean, patients will come in and they tell us they're taking that. They can take really whatever they want. We can't say you can't take something that you buy. The actual benefit of it is not yet clinically proven.
So do you ask about cannabis use?
We don't ask directly, but we ask what else they're taking alongside their prescribed medicine, and normally it is volunteered. The information will always be volunteered.
hmm Is medication adherence an issue in rheumatology?
Adherence can be an issue again right across the board, and sometimes it's very difficult to know whether a patient is not taking the medication that you have prescribed. They will come into the clinic and will say, yes, I am taking it. And sometimes if you're not getting the results that you want, that you were expecting, you do wonder, is the patient actually taking it, or are we not treating with the right medication? And that can be the case as well. Patients very often, well, as you know, they'll talk over the fence to their neighbour and they'll Google and they'll read some of the tabloids and have all sorts of misinformation about their medications. And that does very often frighten a patient who doesn't really know what they're taking. And especially, I mean, you talked about methotrexate, and if they Google methotrexate, and look at the side effects, patients will get very afraid, and sometimes they'll say, well, I don't want to take that because I'm afraid of the side effects. So it can sometimes be a problem. On the other hand, very often our patients do get relief from their medications and they're so glad to have some form of relief that they are very compliant. So there's two sides of the coin.
And something different. What implications does polypharmacy have for the greener NHS?
Polypharmacy is significant. There are about 25% of the carbon footprint is caused by medications in the NHS. That is absolutely huge. So the more steps that we can take to try to reduce the number of medications that patients are taking, it'll be much, much better for the environment.
I see. What is the role of biological DMARDs?
Way back whenever I started in rheumatology, I explained that there weren't all that many drugs. I think I said that there were about 5 or 6 drugs, and I thought, how difficult could that be? And that was the gold and the penicillamine and the methotrexate, and a few drugs like that. About 2000, the first biologic came on the market. It was infliximab, and it was derived from a mouse protein. And that has actually totally revolutionized the treatment of all patients in rheumatology. The biologics are very powerful drugs. They aim to stop the disease in its tracks. And with that, we prevent joint damage on down the line. And really, from nowadays, we don't see in clinic the disabilities that we used to see. We used to see patients in wheelchairs, patients with hands that are very deformed, patients, and that was because the treatments were not adequate. Nowadays, we don't really see that to the same extent. And very often, patients will come in when they're worried about maybe starting a biologic, because it is a big step for them. They'll say, my granny had arthritis and she ended up in a wheelchair, and I don't want to end up like that. And thankfully now with the biological DMARDs, we can prevent the joint damage down the line. So they have been revolutionary in rheumatology.
Could you just remind us what DMARD, DMARD, stands for?
Yeah, a DMARD is a disease-modifying anti-rheumatic drug.
I understand that once a patient is stable on a biological DMARD, the dose can be reduced. Can you explain how this works in practice? And what do patients think?
It's, again, it's a mixed bag. Some patients, once they're established, they are so good in their disease that they don't really want to take the chance of dose extension, which is what we do rather than dose reduction. So, they think if you're getting a drug every 2 weeks, we could maybe try every 3 weeks. Or if you have a drug that's given weekly, we maybe try 10 days or fortnightly. Some patients are very receptive to that idea, and some patients will do very well. Other patients, as I said, are so stable in their drug, they're afraid to make that jump and make that leap. And a sort of indicator is if a patient is off treatment due to infection or due to surgery, and their disease flares very rapidly, those are the patients that are not really likely to be able to dose extend. But every patient, there's no general rule with this. Every patient, as you know, is an individual, and every patient will respond completely differently.
Well, can you just stop them?
Yes, you can just stop them, but usually, if you just stop them, the disease will flare again. Very often with patients who come in and they feel so good, they say, well, I don't need this anymore. And you do try to say, well, I think you're good because of the medication, not in spite of it. And we have had a number of patients who've come in and said, well, I'm stopping, I'm going down the natural route, I'm not taking any more medication. And sadly, almost invariably, they come back in 3 or 4 months and their disease has flared and they're back to square one again. So there's a delicate line between dose extension, stopping drugs, and being well.
Interesting. You've emphasized that in the clinic, you have to think on your feet. Could you give us one or two examples of cases that have made you think and what you did?
In the clinics, I don't know who's coming through the door until they come because I don't have time to prep the clinics. I do 4 clinics a week and I don't have time to prep. So patients come in and I might think they're coming in for one reason and suddenly they present with something different. I have had this, for example, fairly recently, I had a patient who came in and she was on biologics and her rheumatoid was very stable. And by all accounts, she was doing very well. And just as an aside, she says, oh, I have just developed night sweats. I said, right, how often? And she says, well, maybe 3 or 4 times a week, and they're so bad I have to get up and change my t-shirt. Well, that's a red flag immediately. She didn't come in to talk about that, but it was something that was just picked up incidentally. She was an ex-smoker. She was in her 70s. And you immediately think, what is going on here? So that's a case of, thinking on your feet. You can't let that patient go out the door without investigating what is going on.
So in that case, what kind of things were going through your mind?
I'm thinking, well, night sweats. Has she TB? Has she cancer? What's going on? Maybe she doesn't have any of those things, but we need to do bloods, we need to do some imaging, we need to rule out anything that's going on that might be sinister. And that can be picked up coincidentally just by listening to the patient, what they have to say. Another interesting one was a number of years ago, I had a patient who was fairly well controlled, actually very well controlled on methotrexate. I mean, this is way before biologics. And he was a clergyman. He wanted to go to Africa to do some missionary work. And he was coming in to ask about getting his yellow fever vaccine. Yellow fever vaccine is a live vaccine, which should not be administered with methotrexate. So then we had to have a conversation, you have to come off your methotrexate for 3 months before we can give you the vaccine. And your disease may flare. And we talked it through and he said, no, I've made the decision. I'm not going to go to Africa because I can't risk coming off my methotrexate because my disease will flare and it'll not be worth my while going anywhere. So there's a lot of times you just have to think in your feet. Sometimes you look at a patient, they're not responding to how you think they should be responding. So sometimes you have to look at them and think, well, what are we treating? Are we treating the right thing? Are we treating something that's not there? Or, do we need to reevaluate? And that is really important. Guidelines are wonderful in clinic. Guidelines we use them all the time. But one thing that I say to my students all the time, guidelines are guidelines. Guidelines are black and white, and sometimes pharmacists in their training are very black and white, whereas patients are not. Patients are not black and white. They're grey, they're complicated, and you need to think outside the box.
Do you ever end up having to prescribe off-label doses?
Yes, sometimes that will happen. As an independent prescriber in the UK, we are allowed to do that, so it doesn't tend to be a problem for us.
Now, I'd like to come back to the role of the rheumatology pharmacist. You said that you moved from dispensing and counselling to reviewing and managing treatment. That must have been a big step.
It was a huge step. Now, it did happen very gradually as my experience widened. And again, with the introduction of supplementary prescribing and then independent prescribing, that was also a factor in actually being able to see patients. But I remember the very first day that I had my own clinic list, I was absolutely terrified. Because suddenly I was on my own, I had no support. I had these patients coming in with expectations of what they were going to receive at their clinic appointment. And the consultant showed me into the room and she said, yeah, there's your screen, there's your blood forms. Away you go. I'll be down the corridor if you need anything. And that was me just left to it. And it was really at the start, even though I've been doing the clinics gently, it was a steep learning curve just to be thrown in front of patients and be the person who had to make those decisions.
So quite an experience. How do you tell people that you're a pharmacist?
Patients have expectations whenever they come up to a clinic, and mostly they're expecting to see a consultant or be seen by a doctor. Sometimes, not so much with me now because I'm well established, but patients will be a bit thrown by the thought of coming to see a pharmacist or indeed sometimes a nurse. So whenever a patient comes in who I haven't met before, I will introduce myself obviously by my name, and I say my background is pharmacy. And I will be doing your review today. I work alongside Dr. X, whoever that happens to be. Are you happy with that? And it's to try to meet their expectations, to let them know that they are seeing somebody professional who knows what they're about, that they're not just coming up for a medication review, which is the image that a lot of people will have. If you say, I'm the pharmacist, you're coming to see the pharmacist today, they'll immediately whip out their list of medications and think that's all you're going to talk about. And the review is much more than that.
Now, could you offer us some tips for success in rheumatology clinics?
Yes, I think the first thing is you need to be aware of your own limitations. I think that is one of the most important things. Know what you can do and what you can't do. And don't ever be afraid to say, I don't know. There's no shame in saying, I don't know. Very often there'll be patients and I will go to the consultant who looks after them in the long run and say, what are we doing here? And vice versa, they'll come to me and say, what do you think? Will we change to so and so? So it has to be an open conversation. I would say to somebody starting, know your drugs. Make sure that you know your drugs inside out. And you will never know everything about a condition or everything about a drug. A patient will surprise you. And you never say never with any medication. But it is a great specialty. And, patients are complex, but you can see vast rewards with treatment, and I would say get in there and do it.
And finally, for those who have been inspired by your example, what would you say to a young pharmacist who was wondering whether or not rheumatology is a good field in which to specialise?
There are lots of opportunities for pharmacists in rheumatology. especially with the introduction of the biologics. Rheumatology prescribing is complex. Patients have multi-comorbidities. It is a great specialty. You will find it so rewarding. Get in there and just do it.
Hilary McKee, thank you very much for talking to us about this very interesting topic. That really has been inspiring. For more information about Hilary McKee's work, please visit the website using the links in the description. And be sure to subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.